Open the door.
A very good afternoon to one and all. I am Arpita from the IGCP group, the moderator for today's session. The topic that we are going to cover today is surgical management of breast cancer. This is a series session as we are celebrating the Breast Cancer Awareness Month. To address the topic, we have with us someone who is an expert in this field, none other than Dr. Jayanti Thumsi ma'am. It's an honor for me to welcome her to our platform and to introduce her to everyone. Ma'am has done MBBS, then MS in general surgery. She is a lead surgeon at the Department of Breast Oncology at Apollo Hospital, Bangalore. So, ma'am, with this very brief introduction of yours, I would now request you to please start with your presentation. Post that, we'll take the questions from the audiences. Over to you, ma'am.
Right. Thank you very much, Ankita, and hello to everybody. My pleasure to be talking on the recent advances in breast cancer surgery and especially the robotic surgery, which we have newly started. So let us begin. Now, breast cancer, as we know, is the commonest cancer occurring in Indian women, and it accounts to about 39.4% of cancers occurring in women. The incidence of the disease is on rise, and it is estimated that 1 in 29 women is at a risk of developing breast cancer in their lifetime. But what is very disturbing is that in India, about 48% of patients who develop breast cancer are young, they are less than 50 years of age. We have seen quite a number of women coming in their 20s, 30s, and 40s. Many times they haven't even started a family, and that's when they develop this disease. Now, in spite of increasing incidence, breast cancer has one of the highest 5-year survival rate of 81.89%. Innovative research, improved technology, better diagnosis, newer medications has helped cure more and more breast cancer patients. So we need to remember that breast cancer is not only a scientific topic, but also a social issue because it raises concern of survival and also about femininity, body image, fertility, and sexuality. With improved survival rates, focus should be not only on clearing cancer, but also offering a good quality of life. So, what are the treatment options for breast cancer? They can be divided into local regional therapy and systemic therapy. Local regional therapy consists of surgery and radiation therapy, whereas chemotherapy has multiple, systemic therapy has chemo, hormone therapy, immunotherapy, targeted therapy, and many more. Now, talking about the surgical treatment, which is a local regional treatment, surgery is a vital modality for treating breast cancer. In the past, mastectomy was the commonest surgery practiced, but many studies have proven that mastectomy has no advantage over breast conservation surgery. Breast conservation surgery is safe and now is the standard of care for women with breast cancer all over the world. There have been umpteen number of prospective randomized trials comparing modified radical mastectomy versus breast conservation surgery. 6 major randomized controlled trials suggested that breast conservation surgery has survival rates which are equivalent to modified radical mastectomy. Further trials were done to compare the local recurrence rate after breast conservation surgery with post op radiation therapy and without post op radiation therapy. Again, it was proven that post op radiation therapy was associated with decreased incidence of local recurrence, decreased breast cancer specific mortality rate, and the optimal local regional control gave survival benefit in early breast cancer patients. In fact, there have been papers which have proven that mastectomy has a negative impact on a woman. Female breast is a potent symbol of beauty, motherhood, and vitality. Mastectomy as a treatment option means losing a part of the breast and can result in a sense of mutilation. Studies have shown it causes diminished self worth and may threaten perceptions of femininity and affects body esteem. It also causes psychological reactions like depression, anxiety, stress, and affects interpersonal relationships. Hence, cancer clearance with giving a good cosmetic outcome should be the focus. Issues of femininity need to be considered while planning the type of surgery. Breast conservation surgery is the preferred choice, and if mastectomy is inevitable, skin sparing or nipple sparing mastectomy with primary reconstruction should be considered whenever oncologically feasible. Oncoplastic surgery and breast reconstructive surgeries. Oncoplastic surgery is an approach for breast cancer patient that aims at improving cosmetic outcomes. By using these advanced surgical techniques, it not only clears cancer but also prevents undue distortion of breast, maintains aesthetically pleasing breast after all of the treatment is completed. It also permits wider excision of the tumor, reducing the incidence of margin involvement. So just to show some of the pictures of our surgeries, these are the patients who have undergone breast conservation surgery. You can see the scar is hardly seen. This is post-surgery, post-chemotherapy, and post-radiation therapy. This patient had a left-sided cancer. You can see in the upper picture, which was excised, and this was the result in the lower picture. This patient had, again, a left-sided lump. You can see the MRI film there. It looked like a benign lump, and excision has been done, and you can see the symmetry of both the breasts. This patient, again, had a large tumor in the left side of the breast, and post-excision, you can see the cosmetic outcome. Scarless oncoplastic surgery is another technique used wherein the incision is put around the nipple areolar complex and the surgery is done. And through this, we can approach a lump or a cancerous lump in any quadrant of the breast. You can see this patient. We have done the round block technique or the donut breast oncoplastic surgery. You can see the incision or the scar is hardly visible. Also in this patient on right side we have done, and you can see that the scar is hardly visible. When the skin is involved, a part of the skin is involved, bat wing oncoplastic surgery could be used. And you can see here these two patients where bat wings oncoplastic surgery has been done and there is minimal scarring over the breast. With the breast conservation surgery, a tumor and a small portion of the surrounding tissue is removed. However, depending on the size and location of the tumor, this can deform the breast. A local advancement flap is used to reconstruct the original appearance of the breast. This helps in replacing the loss of volume and leaves no additional indentations of defects. You can see these two patients had large lumps, and after excision, the volume loss has been replaced with the latissimus dorsi flap, wherein even the skin from the back is being used to do the reconstruction. These two patients again have got a latissimus dorsi flap reconstruction done. These two patients had the nipple areolar complex involved and hence it was removed and it has been replaced by the latissimus dorsi flap. These two patients, you can see almost half of the breast or the skin is removed from the breast, and this has been replaced by the skin and the muscle from the back, that is the latissimus dorsi muscle. This was a patient we had who had a bilateral lobular carcinoma and the lump was very close to the nipple areolar complex. You can see the incision in the back also after LD flap reconstruction. We can do also implant reconstruction. You can see here this patient, we have done a skin and nipple sparing mastectomy with implant reconstruction, and the incision is in the inframammary fold where it is hardly seen. This patient had bilateral tram flap reconstruction. What is a tram flap? It is a trans rectus abdominis myocutaneous flap. The breast can be reconstructed and also patient gets a flat abdomen, as you can see here. This is 6 months later, right breast reconstruction, post-mastectomy, that is a tram flap reconstruction has been done. Now talking about axilla, when we do axillary clearance, this could result in seroma collection and wound infection. Sometimes there could be stiffness and numbness in the arm or shoulder. there could be lymphedema, and there are higher chances of developing cellulitis of that arm. So in selected few patients, when clinically and radiologically the lymph node is not involved, it's a very early disease. In such cases, we can do conservation in axilla, which is called a sentinel lymph node biopsy. A dual method is used wherein we inject a radioisotope dye, and after that we take the patient to the gamma camera, and with the help of that we detect the node, and in the operation theater we inject the methylene blue dye, and through the gamma probe we detect the lump, which is detected on the probe and which is also blue in color. We excise this lump and we send with this lymph node for frozen section test. Within 20 minutes, our pathologist tells us whether the lymph node is involved or not. Now, if the lymph node is not involved, we can assume that rest of the axilla is also clear and need not do the axillary clearance and subject the woman to all the side effects associated with axillary clearance. So we have clearly moved away from a surgical philosophy that once aimed to remove as much as possible, to remove as much as needed and as little as possible. Oncoplastic breast surgery and reconstruction surgeries combines the techniques of traditional breast cancer surgery with the cosmetic advantages of plastic surgery. The goal is to remove cancer while minimizing the unwanted side effects of surgery, helping the patient heal both physically and emotionally. Now, robotic nipple sparing mastectomy. Robotic assisted nipple sparing mastectomy is the newest addition into the armamentarium of surgical techniques for patients who require a mastectomy. In this, the healthy skin, nipple, and the areola are left intact. Only the breast tissue contained within the envelope of skin is removed. The potential benefits of using the Da Vinci robotic surgical system are it has a small 3D camera and a lighting which offers superior visualization. The EndoWrist robotic instruments offer greater range of motion. Through a minimal 4 centimeter, almost invisible scar, the entire surgery is done. The robotic nipple sparing mastectomy has the advantages of preservation of nipple, skin, and sensation of the breast. It offers 10 times magnification, smaller incision, rapid recovery, lesser pain, and better cosmetic scar, no blood loss, and certainly better psychological outcomes. Yes, there has been a long learning curve for learning robotic nipple sparing mastectomy. First, the training is done on a simulator, and then the actual training happens on where you see a surgeon operating. And then we did robotic training on the animal lab. And then after that, we actually started operating on the patients. And you can see that robotic nipple sparing mastectomy has a long learning curve, but I feel that it is worth learning because it has immense number of advantages, and this is our entire team of doing the robotic nipple sparing mastectomy. And talking about reconstruction post robotic nipple sparing mastectomy, what are the options? We need some reconstruction which is safe, easy to use, and which gives better aesthetically pleasing outcomes. So the titanized polypropylene mesh to cover the silicone implant is something which has been extremely useful and very safe. It has shown to lower the risk of inflammation. It has better compatibility, very good in growth behavior, less foreign body sensation, and improved quality of life. Titanized polypropylene mesh, which is called as Tyloo Bra Pocket or Tyloo Bra, can be used for doing pre-pectoral breast reconstruction or subpectoral breast reconstruction. So it is proven in quality. Umpteen number of scientific papers have been published, which shows that it has low seroma rate, low capsule contraction rate, very good aesthetic results, high quality of life. This is a new tool, robotic nipple sparing mastectomy for breast surgeries. You can see the scar is really, really minimal. So, robotic nipple sparing mastectomy represents a breaking advancement in breast cancer treatment, incorporating technological innovations. This minimally invasive procedure, facilitated by robotic assistance, preserves both the nipple and skin, enhancing the quality of life and cosmetic outcomes for breast cancer patients. By integrating cutting edge robotics into oncological care, we aim at revolutionizing the approach to mastectomy surgeries, offering patients a more precise, effective, and patient centered treatment option. By embracing technological breakthroughs in breast cancer care, we need to underscore our commitment to prioritizing patients' needs. By seamlessly integrating advanced technologies into our treatment protocols, we must ensure that every patient receives the most effective and personalized care possible. From state of art imaging techniques to innovative surgical procedures like robotic nipple sparing mastectomy, our focus needs to remain steadfast on delivering superior outcomes and enhance the overall patient experience. Just a small case discussion. This was a 48-year-old lady, a premenopausal lady, who had an annual health checkup, and on that was seen a microcalcification. This was seen only on mammogram and not on ultrasound. So we did a stereotactic biopsy, and it came as ductal carcinoma in situ. And with the help of the mammogram, we did the wire localization of the lump. In this case, we have done with the ultrasound guided because it was seen on ultrasound. Then the excision of the lump was done and mammogram of the resected specimen. So you can see this is the mammogram first picture showing the guide wire which has been seen and which has in place precisely where the microcalcification is. And after excision, we repeat a mammogram of the specimen to ensure that all of the calcification has been precisely excised. So this one slide which I like to put up by a specialized breast unit, because this was a study which was presented in the British Journal of Surgery. It showed that when a patient is treated in a specialized breast unit as against a general surgery unit, it shows improved survival. Breast surgeries done by surgeons not trained in breast cancer, 45% are incomplete, 80.3% of them had residual nodes, and 52% of them were already metastatic. Thank you very much, dear friends. It has been a pleasure talking, and I will be very happy to answer any questions that you have.
Thank you, ma'am. Thank you so much for this beautiful presentation. Now I would like to take the questions from our audiences. Ma'am, the first question is, what are the latest advancements in surgical techniques for breast cancer that offer improved outcomes in minimal invasiveness?
Yeah, so the outcomes are not compromised at all. Obviously, the idea is cancer clearance first and then cosmetic outcome. But if we can do both, yes. So minimal invasive surgery, like I said, we use the robotic nipple sparing mastectomy. Not all patients are eligible for it. The eligibility is that the nipple areola should not be involved, skin should not be involved, or in such a case we would probably give a neoadjuvant chemotherapy first. So the idea is when there are very young women who develop multicentric disease and we have to do a nipple a mastectomy, in those cases robotic surgery is very, very useful. So when we do a mastectomy using the robotic arms, we always do a frozen section of the specimen so that we know that the disease is completely cleared and that the margins are free. We also do frozen section of the retroareolar tissue to ensure that there is no disease behind the nipple. So yes, the safety is taken care of when we do the minimal invasive surgeries.
Right, ma'am. Thank you so much. Moving on to the next question. Could you please elaborate on how the choice between breast conserving surgery and mastectomy is made for different patient profiles?
Right, that's a very good question. So for that, we need a mammogram. A mammogram is an ultrasound, which is useful for women who are 40 years and above. But if the patient is very young or if she has a very dense breast, then we would also do a breast MRI with contrast. So that will tell us whether there is only one lump or are there multiple lumps. Now, if there is only one lump, then we can safely do breast conservation surgery. But if there are multiple lumps in different quadrants of the breast, then doing mastectomy would be a better choice. And you should always counsel the patient that after breast conservation surgery, radiation therapy is a must. Now, if for some reason, if the patient is not able to take radiation therapy, in such cases, please do not do the breast conservation surgery, and doing a mastectomy would be a better option. So, whether it is a multicentric disease or is it a single disease will determine whether we will do mastectomy or breast conservation surgery, and that can be detected on mammogram or ultrasound or in a young patient on breast MRI.
Right, ma'am. Thank you so much for clearing this confusion. Moving on to the next question, ma'am. How has the integration of reconstructive surgery evolved in breast cancer treatment, and what options are most commonly recommended?
Yeah, so I have already shown some pictures. We do oncoplastic surgeries or breast reconstruction surgeries. Breast reconstruction surgery can be either implant based surgery or it can be autologous, that is, using patient's own tissue. So, in implant based surgeries, earlier, as you saw some pictures, we were using the LD flap to cover the implant. Acellular dermal matrix is available, but it is very, very expensive. So, we could use it on very minimal patients. Doing a pre-pectoral implant reconstruction in India is a little difficult because women here tend to have bigger breasts and little sagging breasts as compared to, say, patients in the region of China, Korea, uh, Taiwan. All those patients, they have a different kind of build. They have smaller breasts, and in them, doing a pre-pectoral implant would be easier. But in our country, we see lot of women having larger breasts, and in such cases doing a prepectoral implant may be difficult, so we do a implant reconstruction over the pectoral muscle. So the implant needs to be covered with something. So we were earlier using latissimus dorsi flap, but now with this titanized polypropylene mesh, I feel the job has become much easier, and it is extremely convenient. We do not have to use any LD flap. The mesh itself gives a good coverage. It gives less seroma. The healing is also better, and the foreign body sensation is not there. Capsular contracture is also less, is what we have realized. So, but that if a patient do not even want implant reconstruction, then we have other options like doing tram flap or DIPP flap, and there are many flaps which are basically free flaps and which needs microvascular surgery.
Right, ma'am. Thank you so much. We have one other question, that is, what are the key factors influencing the timing and planning of surgical interventions following a breast cancer diagnosis?
Well, so when we do surgery and when we give upfront chemotherapy, that is neoadjuvant chemotherapy, depends on the age of the patient and the type of the disease. Now, if we have patient who has a triple negative breast cancer or HER2 enriched breast cancer, or there is a woman who has a locally advanced breast cancer, in such cases, we would give neoadjuvant chemotherapy first. That means we would give upfront chemotherapy, and after that, after completion of all the chemotherapies, we plan surgery. Now, there are some women who have large tumors who would otherwise land up in a mastectomy, but they are interested in undergoing breast conservation surgery. In such cases, also, we give neoadjuvant chemotherapy through which we can actually downstage the disease. The lump will become smaller in size, and the patient who would otherwise have landed up in mastectomy now becomes eligible for breast conservation surgery. However, if there is a patient who has ERPR strongly positive, in those cases, probably we will do a upfront surgery. And what kind of surgery, as I've already mentioned, depends on whether it's a multicentric disease or a single disease.
Right, ma'am. We have one last question. If you can discuss the role of lymph node surgery in breast cancer and how sentinel lymph node biopsy has impacted patient outcomes.
Right. I think I've already covered in my presentation. However, I will repeat it. Now, if we have a patient who has a very early breast cancer, that means there is a lump in the breast and the axilla does not seem involved radiologically or even on physical examination. You feel that the lymph node is not involved. In such a case, we need not remove all the axillary lymph nodes. We need not do a complete axillary clearance, because complete axillary clearance can lead to lymphedema, it can lead to stiffness of the shoulder and quite discomforting to the patient. So in those cases, we can safely do sentinel lymph node biopsy, but always a dual method should be done because that is far more far more safer to do than using only a single agent. So we use a radioisotope dye, and we also use methylene blue. These two methods together, we do a sentinel lymph node biopsy. So we regularly do it for patients who have early breast cancer. But also in some of the cases where there is an elderly patient, very old patient, and on whom you have to do axillary clearance. So in those cases, we can do a sentinel lymph node biopsy. And if only one lymph node is involved, say you have removed 3 lymph nodes, send it for frozen section, and only one lymph node is involved. In such cases, when you are anyway going to give radiation therapy, such selected women can be spared from axillary clearance. So sentinel lymph node biopsy is what should be practiced, and please do not subject women to unnecessary axillary clearance and all the problems associated with it.
Right, ma'am. So these were the questions for today. Ma'am, with that, I would like to conclude the session. But before that, I would like to thank you wholeheartedly from the team of IGCP and from all our viewers. Thank you so much, ma'am, for putting your effort in making the presentation and for taking all the questions, clearing all the doubts that have come from our audiences. So, ma'am, thank you so much for your effort, for your time, and for everything. Thank you so much, ma'am. We are really honored.
Thank you very much. Thank you very much.
Ma'am, I think there's one last question. That is
Yes.
SMV treatment tablets. Someone has asked this.
What's that?
SMV.
What is SMV?
It's not clear. Ma'am, can you see it? I have like SMV treatment tablets.
Oh, I don't know what this is. You'll have to elaborate it.
Okay, ma'am.
Or the person can mail me the question. My mail ID is up there on the screen. Please mail me the question and I will try to answer it.
Right, ma'am. Ma'am, thank you so much for your time. Thank you, ma'am. With that, we are concluding the session for today.
Thank you very much. Thank you.